Thanks very much, Donal, and good evening, everybody. I'm really pleased to be here for what is my first MacGill. And I think most of the regulars can't believe that I was never here before, but I'm really looking forward to it. And we heard that Donal goes out swimming at 8 o'clock in the morning, but he also said to me that, running at 8 o'clock in the morning. He also said to me his main job is to make sure we wrap up here by 11 o'clock at night, because the best fun is to be had after 11 o'clock. So I'm really looking forward to that too. So I'm going to talk for a while this evening about the whole project of Sláinte Care and the cross-party agreement on the way forward in respect of health. So Professor Tom Keane, who oversaw the successful implementation of the cancer strategy, recently gave an interview about the Irish Health Service on the Sean O'Rourke programme. And in that, he said that the service was reaching, I quote, a tipping point of total system failure. In a situation where nearly 60% of the population do not have timely access to healthcare, we are looking at what he called an apocalyptic situation. Professor Keane went on to say that in any other country in the world, if this was happening, the government would not survive. It would be beyond what would be even reasonably acceptable, and that it is astonishing that people are not taking to the streets. Well, people haven't taken to the streets in any great numbers, not yet anyway. But they had plenty to say when we met them on their doorsteps recently. As we canvassed for last year's general election, household after household spoke angrily and fearfully about the crisis in our health service. Health was, by a large margin, the number one issue of concern. And yet, incredibly, neither of the two largest parties made any new proposal in their manifestos to solve the crisis in health. The election took its course, the votes were counted, and in time the media turned back to the crisis in the health system, to the drip of horror stories about years-long waiting lists, soaring insurance costs, and the routine denial of timely, effective treatment to people in the direst need. And then at last, in Leinster House itself, there was a growing cross-party sense that something needed to be done about health. For years, there had been calls to depoliticise health and to draw up a long-term agreed strategy to settle the problem for once and for all. Now, as the crisis got worse, there was a growing sense among politicians of all stripes that we needed to move beyond the talking stage. One accidental benefit of the lengthy post-election interregnum was that it gave many politicians some pause for thought, an opportunity to respond to public concerns and to take a new approach to our dysfunctional health service. It was against this background then that the Social Democrats drafted a Dáil motion on cross-party health reform, to which 89 other TDs immediately signed their names. Soon after that, the new government was installed, and the new minister and his colleagues came on board. What followed was a unanimous vote of the Dáil to establish a cross-party committee to be called the Committee on the Future of Healthcare. The committee was tasked with reaching a consensus on a 10-year strategy for reform, and critically, it was specified right from the very start that this would include the establishment of a universal, single-tier health service, a fair and compassionate health service, which would treat all patients on the basis of their health need rather than on their ability to pay. 14 TDs representing all parties and groups within the Dáil came together to form this new committee, and I was very pleased to be elected as chairperson. For your interest, the other members of the committee were Kate O'Connell, Bernard Durkin, Hildegard Naughton and Josepha Madigan of Fine Gael, Billy Kelleher, John Brazel and John Brown of Fianna Fáil, Louise O'Reilly and Pat Buckley of Sinn Féin, Joan Collins of Independence for Change, Alan Kelly of Labour, Mick Barry of Solidarity, and Independent TD Dr Michael Harty. So representing all views right across the full spectrum in the Dáil. This was a first for us all. In fact, it was a first for the Dáil itself. Never before had a Dáil committee attempted to reach a political consensus on policy, a policy relating to an area of major public importance. Unlike most developed countries, we in Ireland have never sought to identify the most appropriate model of healthcare for the Irish people. A very disjointed, inefficient and inequitable system has evolved over the years. A system which fails to adequately meet many of the most basic care needs of the people. In no other European country are so many people denied access to services or forced into private health insurance. In theory, almost 40% of people here are eligible for free public health care. But the key word here is eligible. They may be eligible for treatment, but they are not entitled to it. And that is because in practice, many of the services they are theoretically entitled to either do not exist or are hopelessly inadequate. This is why people can wait years for a routine outpatient appointment to see a publicly sponsored consultant. And because of the grave shortcomings of the public health system, another 45% of the population feel they have no choice but to take out expensive health insurance, the premiums for which rise every year, just so that they can be sure of access to hospitals and to diagnostics that in most cases are already paid for by taxation. All service users, whether public or private, are faced with significant out-of-pocket expenses that have risen substantially in recent years, often to a catastrophic level, where many are denied access to essential care. In the Irish context, the inverse care law applies with brutal force. Those most in need of care are least likely to receive it. From the start, the Committee on the Future of Healthcare agreed that our approach would be evidence-based, that we would listen to service users and staff, that we would take expert advice, and that we would learn from best practice in other countries. Importantly also, I think, we agreed a set of principles which would underpin our work and the development of the strategy. Included in these was a belief in the primacy of the patient, the need to make timely care free at the point of delivery, based entirely on clinical need. And we also agreed that these services would, in the main, be provided in the primary care and community setting. It's important that we do that away from overcrowded, overworked and stressful public hospitals and close to where people actually live. We also determined to support and value the health service workshop. We also determined to support and value the health service workforce, while at the same time introducing much greater oversight and accountability. Over the course of our work, committee members came to realise just how much of an outlier Ireland is in terms of poor access to care, high user costs, long waiting lists, and the fact that some 45% of the population feel obliged to pay for private health insurance. This compares, for example, with the UK, where approximately 12% of people have private health insurance. As Dr. Tom Keane said, it wouldn't be tolerated anywhere else. On the committee, we resolved to ensure that people in Ireland would have the right to timely access to quality public health services, similar to the rights enjoyed by most of our European neighbours, even in states that are smaller and poorer than we are. We also recognised that we need to build long-term public and political confidence that a solution is actually possible. Ireland's health system has been failing its people for so many years now that many have come to assume that the situation is hopeless, that it must always be thus, that there is nothing to be done about it. Yet this is clearly not the case. Ireland is not a poor country, and much poorer countries than ours have managed to run decent health services. We therefore realise that our first and most important task on the committee would be to make other people believe that change is possible. And to do that, we had to learn to believe that ourselves. And so, 11 months after we took up our work, we had convinced ourselves, beyond any doubt, that we had found the solutions. We had considered 160 public submissions, held 4 months of open hearings, and worked intensively with an expert team from the Centre for Health Policy and Management in Trinity College. And the fruit of all of this consultation, research, and innovative thinking was a new cross-party strategy that we called Sláinte Care. Sláinte Care, like the committee that produced it, really is a first for Ireland. It is a fully costed plan which maps a clear path away from the current dysfunctional, inequitable, and inefficient two-tier health system, replacing it with a modern, responsive, and universal public health service comparable to the systems of most developed countries. As a committee, we put a strong emphasis on implementation. We were determined that Sláinte Care would not be left to gather dust. That is why we proposed a separate, fully resourced implementation office under the auspices of the Taoiseach and working within the health service. The sole remit of this office would be to make the reform programme actually happen. Fixing the health service can be compared to repairing an aircraft while in flight. It needs to be kept in the air while the work is being done. Similarly, all of the urgent day-to-day demands of a creaking system have to be coped with and responded to, while also implementing a radical and fundamental system change. We didn't have the luxury of suggesting that we would halt everything to set up a new system. Old and new must work in parallel during the transition. Of course, that transition period needs to be funded properly, and that is on top of existing expenditure. The committee was very conscious of the fact that in Ireland we spend more on our failed health system than most other OECD countries, and all of those countries have properly functioning health services. But we were also conscious that we will not see critical change in the way that we deliver services unless we provide upfront funding to make the reforms happen. It is necessary to prime the pump, to spend more now, so that in future we can spend relatively less to see much better outcomes. We are proposing a significant move away from our overly hospital-centric model of care. That model of care that we have at the moment is expensive, inefficient, and far too prone to blockages and poor administration. And we want to move instead to a system which puts the focus on primary and social care, close to where people live and to the networks that sustain them. This means investing in primary care centres and community diagnostics. Rather than forcing people to travel long distances to overcrowded hospitals to sit in emergency rooms, which they don't really need, or to access routine outpatient services. It also means recruiting the nurses, doctors, and other key health professionals who can provide the much-needed additional capacity at community level. In this way, we can have a much greater emphasis on prevention and early intervention and ensure that the huge burden of chronic disease can be managed much more effectively in a community setting. If we can make this switch, we can achieve much better health outcomes and, of course, much better value for money. Similarly, we propose early investment in the e-health programme, which, if implemented in full, has the potential to radically transform the information systems in our health service and greatly improve efficiency. E-health is a programme which would give each individual patient a unique identifier, allowing them and their records to be transferred seamlessly throughout the health system. Such data management is vital to understanding how the population, both nationally and regionally, engages with the health service. It would also, of course, provide necessary information on the geographical and service areas where resources are most needed. In this way, we could have better forecasting and financial planning for services, as well as ensuring greater accountability for performance all round. The committee has proposed a transitional fund in order to make up for the substantial underinvestment in facilities and IT during the austerity years. This fund would also train the additional primary care staff in order to expand capacity at community level. The amount required for this is a once-off €3 billion spread over the first 6 years. In addition, we recommend the continuation of the annual 7% increase in the health budget, which we've seen in each of the last 2 years, in order to fund the proposed universal package of care. The need for more accountability in our health system, and particularly in our state-funded hospitals, was behind the most radical but also the most urgent recommendation of our committee. This was the clear and pressing need to disentangle our public system from private medicine. Our hybrid system, unique in the Western world, permits senior doctors to use publicly funded hospitals and diagnostics to treat their private patients. The state invests hundreds of millions of euro in so-called voluntary hospitals, which, when called to account, comport themselves as private entities with no need to answer to the public interest. There is a huge lack of transparency about the level of cross-subsidisation from public funds to doctors and senior managers in publicly funded hospitals, to the health insurance firms that place their clients in those hospitals, and to the supposedly separate private clinics which many voluntary hospitals operate alongside their state-sponsored operations. It is impossible to establish whether we are getting value for money from our public hospital beds, for example, or from our publicly funded equipment, our consultants, or other healthcare staff. And without a clear line of sight of resources, transparent data, and effective information systems, it is not possible to establish accountability at either administrative or clinical level. Absurdly, public hospitals are given annual targets rising year on year for income generation from private patients. Meanwhile, hospital consultants, who are already paid generous public salaries, are permitted to see private patients on the side to top up their earnings. This mashing together of public interest and private gain creates a classic perverse incentive, paying publicly funded hospitals and consultants to treat private patients ahead of those in the public system whose needs may well be greater. Is it any wonder then that we have 660,000 people on waiting lists for hospital services? The mixing of private incentive and public interest at the heart of our health system creates what can only be described as an ungovernable twilight zone. All we know for sure about them is that public money flows into them and private money comes out in the form of top-ups and special payments for senior doctors and executives. How this alchemy comes about is, we are told, none of our business. Throughout the committee's work then over the past 11 months, we have been acutely aware that we are facing an historic opportunity to do something of real consequence for the country, to agree a 10-year strategy for a new and comprehensive health system. We have a unique opportunity, a once-in-a-generation chance to draw up a viable plan to ensure equitable access for all citizens to a high-quality, universal, single-tier health system. Sláinte Care is not pie in the sky. It is not just another catalogue of fond aspirations. It is sober, costed and practical, and can easily be delivered in full over the next 10 years. Yes, it does require a commitment to provide substantial transitional funds in order to make this change happen. And yes, there are many competing demands for finite resources. But uniquely for Ireland, we now at last have a plan for a health policy based on real political consensus. It has the support of patient groups, advocacy groups, and many of the social partners. What is required now, in my view, is political courage to say, this is what we must do if we want an equitable, modern and efficient health service. This is the right thing to do. Sláinte Care is now the only game in town. There is no alternative plan. We must not squander this opportunity. Thank you very much, everybody.